Hi, it's me, Dr. Mohammad Kazafi, and you are watching Dr. Mohammad Kazafi Views. And my topic is a Brown-Séquard syndrome, in which the hemisection of the damage of the spinal cord. I just want to give you a historical background that the Sir Charles Edward Brown-Séquard was born in Port Louis and in Mauritius, and he died in 1894 in Paris. And he was a physiologist and the neurologist. He represents that there is a Brown-Séquard syndrome, in which the half of the spinal cord cut in a, and or damaged because of some reason. There's a loss of temperature, sensation, temperature, touch, pain. Everything has been lost, and then the power muscle has been lost. So this is some humble introduction for the Sir Brown-Séquard syndrome. I want to present one case and just for the analogy, and then we will go for the topic in detail. As you know, the 16-year-old girl is involved in a serious motorcycle accident, and the patient exhibits a fracture dislocation of a vertebra. The signs and symptoms include bilateral loss of pain and thermal sense with the area of the fracture, a lower motor neuron symptoms, and the vasomotor paralysis in area and supplied by the injured segment on the right side, and the loss of sensory impulse in the posterior white column below the lesion on the right side, and the upper motor neuron lesion below the level of injury on the right side. So the symptom described, this is the most suggestive for that there is a Brown-Séquard syndrome. And you know, this girl, which is a 16-year-old girl, got the serious motorcycle accident and got the fracture dislocation of the vertebra. And I presented the sign and symptom regarding her, that the bilateral loss of the pain and thermal sensation and in the area of the fracture, and the lower motor neuron symptoms, and the vasomotor paralysis in the area supplied by the injured segment on the right side, and the sensory loss of impulse in the posterior white column below the lesion on the right side, and the upper motor neuron lesion below the level of the injury on the right side. So these are the details regarding this, and the Brown-Séquard syndrome diagnosed. Then Brown-Séquard syndrome characteristically result following a hemisection of the spinal cord, and it is characterized by loss of motor function on the side of the lesion and the loss of a protopathic sense on the contralateral side. It is the most commonly caused by penetrating or blunt trauma, but can also be caused by the mass occupying lesion, bleeding disorder, and the disc herniation. Syringomyelia typically present in the loss of pain and temperature sensation in a cap-like pattern. Anterior cord syndrome result in a loss of motor as well as pain and temperature below the level of the spinal cord, and the posterior cord syndrome result in a loss of proprioception and the vibration sensation below the level of the injury. So I just remind you little differential diagnosis here. When we are presenting, this is definitely our provisional diagnosis, and confirmed diagnosis is the Brown-Séquard syndrome. We definitely characteristically result with the following hemisection of the spinal cord, and it is characterized by the loss of the motor function on the side of the lesion, and the loss of the protopathic sense on the contralateral side, and it is most commonly caused by the penetrating or the blunt trauma, but can also be caused by the mass occupying lesion or bleeding disorder or disc herniation. But if we go for the differential diagnosis, for example, syringomyelia typically result in a loss of pain and temperature sensation in the cape-like pattern. Anterior cord syndrome result in loss of motor as well as pain and temperature below the level of the spinal injury, and the posterior cord syndrome result in a loss of proprioception and vibration and sensation below the level of injury. So I want to explain little in detail. Before going to for further, I just wanted to present this slide for you people. This is the right-sided hemisection of the spinal cord here, and you can appreciate that the areas involved in this in this picture, and you can appreciate what happened with the when these kind of the problems will happen. Here you can see there is a loss of all sensation in that area. In the black area, all sensation has been lost because this is the same area at the level of the problem, and you can appreciate there the loss of pain and temperature in the contralateral side, and paralysis on the ipsilateral side, and loss of proprioception and vibration also in the ipsilateral side. So you have to remember these four things because the right-sided hemisection of the spinal cord at T12 and the T12 level, which is showing with the black dermatomal, there's a loss of all sensation. Patient can't feel anything, but simultaneously you can appreciate here the loss of the pain and temperature in the contralateral side, and the paralysis of the ipsilateral side, and loss of proprioception on the and vibration on the ipsilateral side. For the detail, I want to explain in front of you. There is that Brown-Séquard syndrome is an incomplete pattern of injury showing a hemisection of the spinal cord, which result in a weakness and paralysis on one side of the damage and loss of pain and temperature sensation on the opposite side. This depends on the site of injury, and which can also involve the cervical or sympathetic thoracic trunk, resulting in Horner syndrome. Overall, the symptom depend on which part of the spinal cord is affected. It is also known as the hemisection of the spinal cord. As an incomplete spinal cord syndrome, the clinical presentation of BSS may range from mild to severe neurological deficit. The most common cause of the Brown-Séquard syndrome can be divided into traumatic and non-traumatic injuries. Traumatic injuries are far more common, and the gunshot wound, stabbing, or the motor vehicle accident, blunt trauma, or the fracture vertebra from a fall could be among the cause. To a lesser extent, Brown-Séquard syndrome can result from a vast variety of non-traumatic causes, including the vertebral disc herniation, cyst, cervical spondylosis, tumor, multiple sclerosis, and cystic disease, radiation and decompression sickness. Other miscellaneous vascular reasons include hemorrhage or ischemia. There could be infectious causes like the tuberculosis, transverse myelitis, herpes zoster, empyema, and meningitis. In United States alone, about the 11,000 new cases are reported each year among the spinal cord injury, and which include the paraplegia and tetraplegia. Brown-Séquard syndrome is a rare form of the incomplete spinal cord injury, which results from the damage to one side of the spinal cord only, and typically in the neck, cervical spinal cord, or thoracic spinal cord. However, it could be anywhere along the length of the spinal cord. So this estimated indicate among all traumatic cases, 4% of the spinal cord injury are Brown-Séquard syndrome. Pathophysiology with the Brown-Séquard syndrome, a clean-cut hemisection is usually not visible. However, partial hemisection is evident and often include all the nerve tract and lying along the path in the injured area involved. And if the lesion is involved in the cervical region, for example, C5 to T1, the hemisection could create deficit in the following manner. All sensory sensation could be lost ipsilaterally, and the dorsal column sensation, which are responsible for fine touch vibration, 2-point discrimination, and the conscious proprioception, could be affected on the same side of the lesion because dorsal column ascend ipsilaterally, carrying the information from the lower half of the body in the gracilis fasciculus and the upper half of the body in the cuneatus fasciculus before they decussate into the lower medulla. Because we have to understand here the pathophysiology, so I want to explain in humble manner that the Brown-Séquard syndrome, a clean-cut hemisection is usually not visible. And partial hemisection is evident, and it often includes all the nerve tract lying along the path in the injured area involved. And if the lesion is involved in the cervical region, for example, between the C5 to T1, the hemisection would create deficit in the following manner. And the first thing, all sensory sensation would be lost ipsilaterally. For example, dorsal column sensation, which are responsible for fine touch, vibration, 2-point discrimination, and conscious proprioception. These all are the dorsal column sensation. There's fine touch, as I told you, vibration, and the 2-point discrimination, and the conscious proprioception. These all are, we can say these are the dorsal column sensation, and would be affected on the same side of the lesion because the dorsal column ascend ipsilateral and carrying the formation from the lower half of the body in the gracilis fasciculus and upper half of the body in the cuneatus fasciculus before they decussate in the lower medulla. So that's why if the C5 to T1 area involved, then definitely the lesion involved ipsilaterally. Means because the same area affected, for example, right cut, then the right cut sensation, dorsal column sensation, vibration included your touch or fine touch or the 2-point discrimination and the conscious proprioception, all will be gone. Spinothalamic tract that are responsible for the pain, temperature, and the crude touch could be affected contralateral to the lesion because they ascend a level up and then cross to the opposite side of the cord. So because they ascend up to the opposite side of the cord, they ascend just a level up and then ascend up to the opposite side of the cord. So the contralateral spinothalamic pathway, which are responsible for the pain and temperature and the crude touch, they are affected on the contralateral side. Dorsal and ventral spinocerebellar tract carrying the sensation of unconscious proprioception, lesion affecting the dorsal spinocerebellar tract cause ipsilateral ataxia, and involvement of the ventral spinocerebral would cause contralateral dystaxia since these fibers ascend and cross to the opposite side. Because the ventral spinocerebellar fiber are decussated one level above, and then after decussation they go up. So that's why they are doing the ipsilateral dystaxia. But because of the dorsal dorsal spinocerebellar tract, it called the ipsilateral dysataxia, and the ventral spinocerebellar tract caused the contralateral dystaxia. So these are the thing you have to remember. We have to remember for this, and you know that the Horner syndrome, if the lesion is at above T1, this will cause ipsilateral loss of sympathetic fiber and resulting in ptosis, meiosis, and anhydrosis. And there might also be redness of face due to the vasodilatation. Horner syndrome can be happen, and if the lesion is at or above the T1 level or the cervical level, then this will cause the ipsilateral loss of the sympathetic fiber and resulting in ptosis, meiosis, and anhydrosis. And this might be the redness of the face due to the vasodilatation. Corticospinal tract, where would be an ipsilateral loss of movement at the site of the lesion, which represent with the flaccid paralysis, lower motor neuron lesion like loss of muscle mass, fasciculation, and the decreased power and tone. Below the level of lesion, there would be a upper motor neuron lesion, sign like paralysis with hypertonia, Klepp's knife type or hyperreflexia and positive Babinski sign, and there is no significant motor deficit on the contralateral side. I think this picture is showing lot of information for you. Here you can see the dorsal column, there is a lesion, the lower thoracic level, as just an analogy to understand that. And you can see when the lesion in the lower thoracic, the dorsal column and the anterolateral column, you can see in the blue, there is a reduced sensation of the temperature and the pain, and you can see the level above everything is okay, lesion is normal. Sorry, the normal sensation. At the level of lesion, you can see in the green there is this area completely lost the sensation, and in the ipsilateral side you can see reduced 2-point discrimination, vibration, proprioception, means all dorsal column sensation has been lost. So I think this picture is showing lot of. The detailed history and the physical exam are extremely important to understand the extent of the damage done and establish what to expect in coming days. And regarding the neurological deficit, account should have the detail of an injury, and careful examination of the wound site is necessary because it may reveal an injury to dorsal column system and the spinothalamic tract, dorsal and the ventral spinocerebellar tract, corticospinal tract, Horner syndrome, and if the lesion is above or at the level of T1, and if the wound is involving the lower lumbar region, then the bladder and the bowel symptom can be detected or respiratory symptom. If lesions are near the brainstem, usually incomplete form of the syndrome commonly occur, and this can be caused by the vascular impairment secondary to compression of the cord, or history is necessary to rule out the infectious cause, or recent level of the academic area should be ruled out. A neurological examination should comprise a detailed motor and sensory evaluation, although sometimes it is hard to perform a physical exam in the beginning, especially after trauma. Because patients are in spinal shock and clinically there may be a ipsilateral sensory loss of the all sensation, pressure, vibration, position, and the flaccid paralysis at the level of the lesion, and spastic paralysis below the level of the lesion. Contralaterally, there would be a loss of pain and temperature. An evaluation here, the diagnosis of BSS is made by neurological history, by trauma history, and the physical examination, laboratory investigation in search of the infectious etiology like purified protein derivative and the sputum for the acid-fast bacilli, along with chest X-ray, magnetic resonance imaging, X-ray when traumatic injuries are expected, as well as neoplastic cause. The treatment for individual with the Brown-Séquard syndrome depend on cause, and it focused on preventing complication, and the use of the steroid is controversial in traumatic spinal cord injury due to the risk of infection, and they are not effective in the case of the Brown-Séquard syndrome. But standard perioperative prophylactic antibiotic are recommended, and decompression surgery is considered for patients who have traumatic injury or any tumor or abscess causing cord compression. Non-operative treatment to support individual with an emphasis on the less dependency for daily activities and improving quality of life with a interdisciplinary approach involving a spinal cord injury physician, nurses, occupational therapists, and the social worker. So the specific device can help to improve the quality of life and the daily activity of the patient with BSS. With the Brown-Séquard syndrome, such as the wheelchair, limb support, and the head splint. If the patient has difficulty in breathing or swallowing, various aid can be applied, and the cervical collar can also be used depending on the level of injury. In the case of the thoracolumbar region involvement, the spinal orthosis can be used. Differential diagnosis should include stroke, tumor, or cyst. The other causes of spinal cord injury and compression include the epidural hematoma, epidural abscess, syringomyelia, anterior cord syndrome, central cord syndrome. A careful recording of history will help to establish the baseline functionality of the patient before and after the injury is very important, because it will distinguish an acute disorder from a chronic clinical picture. For example, asymmetric myelopathy can be confused with Brown-Séquard syndrome, but history will reveal a slower progression of the symptom in the presence of the straightforward clinical exam. Fluctuating asymptomatic symptom would suggest spinal cord demyelination syndrome, such as multiple sclerosis or Brown-Séquard syndrome. Prognosis for individual with Brown-Séquard varies depending on the cause of the injury and the extent to which the spinal cord is damaged. Generally, Brown-Séquard syndrome is an incomplete spinal cord injury. The potential for significant recovery is strong, and more than half of the Brown-Séquard syndrome patients recover well, and the majority of post-traumatic patients recover motor function. Recovery becomes slower throughout the 3 to 6 months, and it can take up to 2 years for ongoing neurological recovery. If the deficit is at the level where it affects bowel and bladder, patient may gain their function in 90% of the cases, and the most patient will regain some strength in the lower extremity, and the most will regain the functional walking ability, and which when motor function loss is present, recovery is faster to the contralateral side and lower on the ipsilateral side. So this is regarding the prognosis of individual. Definitely it is not universal, but some guidelines or some ideas in front of you we can present, like the Brown-Séquard syndrome varies depend upon the cause of injury and extent of the spinal cord is damaged. Generally, it is incomplete spinal cord injury for potential for significant recovery. Definitely it is strong, but more than half of the Brown-Séquard patient recover well, and the majority of the post-traumatic patients recover motor function, and recovery becomes lower throughout 3 to 6 months, and it can wake up to 2 years for ongoing neurological recovery. If the deficit is at the level where it affects bowel and the bladder, patient may gain their function in 90% of cases, and most patients will regain some strength in the lower extremities, and the most will regain the functional walking ability. And when the motor function loss is present, recovery is faster on the contralateral side and slower on the ipsilateral side. Untethered Brown-Séquard syndrome, untreated Brown-Séquard syndrome may bring complications like hypotension, spinal shock, depression, pulmonary embolism, infection most commonly in the lungs and urinary tract. Respiratory support is critical for patients with the high thoracic and the cervical lesion. Early treatment leads to prompt symptom resolution in most patients, with physical therapy and rehabilitation begin the most essential. Brown-Séquard syndrome has the best prognosis for ambulation of all spinal cord injury, with up to 90% of the individual walking without assisted device for rehabilitation. Historically, rehab was initiated at 1 to 2 weeks after the patient is stable, but recently there is a move toward the earlier immobilization. Uh, to overall prognosis, it not depend solely on one provider, but rather is the interprofessional team for the expert, and timely diagnosis and awareness among other physician, family practitioner is particularly important. And then this is a big teamwork required for this, and it will help in that regard. So I want to show you one thing here. You can see this lesion, you can see in the sagittal, there is an arrow there, and I am with my pointer, I am just showing there is a lesion like this. So these kind of lesion definitely an example for the Brown-Séquard syndrome. So it is for the information. I want to show you one thing. Definitely this is the example I show, and you can see here at the cervical level, this is the example for the Brown-Séquard syndrome, and appear it like this. And I want to show you one thoracic area for this. I think you can appreciate here, there is a half of the area is pushed and affected, or here you can see there is a lesion. So this is the thoracic example, and before that I show you the cervical example. And further, my video is telling lot of things, you can listen it and you will find. You can apply the AI, so you can find the English language in the written form. Thank you so much for supporting, liking, and appreciating me.